Hello, everybody. My name is Michael. I'll be your moderator today. Just bear with me here. Can I get slides up? And we'll be beginning in a couple moments. All right. Bear with me. Going to get, there we go. I got my slides. Hope you're all having a wonderful day, by the way. Dr. Doane, how are you today, sir?
Super. How you doing?
I am fantastic. And so I want to welcome you as well as everybody else that's kind of joining us here on our webinar. I'm going to do a little bit of a housekeeping and then kind of lay the frame for what we're going to be going through on the webinar. So ladies and gentlemen, if you're watching this live or you are watching this as a recording, thank you so much for your attention. And today we're going to talk through a lot of different vision correction options that are available to you, regardless of your age. And so everything from LASIK and SMILE to ICL, refractive lens exchange, for those of you that are maybe over that 55-year-old range and kind of wondering what's going on with your vision. Really just to set the frame for you is we want to make sure that you have an opportunity to ask any and all questions. So I'll be moderating them with Dr. Doane and being able to kind of ask those. We're also going to make this Q&A style, right? So I'm going to show you a lot of the questions that we do have available for discussion. And then lastly, the end goal of this webinar is not to actually make you convince you to have surgery. It's really, do you want to find out if you're a candidate? And so, Dr. Doane, before we begin, anything you'd like to say to people that are watching this live or on a recording?
I just want to say welcome everybody, and certainly hope we answer a lot of questions and get people up to date on possibilities if they're not happy with where they are. And the where they are, maybe I can see all right with my glasses or contact lenses, but I hate them, or I really want to do something different.
Excellent. So we got your credentials up on the board. Obviously, you've got a tremendous amount of experience, and I'd love to give you an opportunity just on a personal level. What is it that you love the most about ophthalmology? What is it that you what brings that smile to your face every single day as far as the patient care that we provide, and just anything you wanted to give about just your personal journey, please?
Yeah, virtually everybody that I think the most important thing on a daily basis, virtually everybody that we treat, we can help. And most of those people that we get to see and treat, and I've been doing refractive surgery, or trying to get people out of glasses or contacts for almost 30 years. It's pretty much a daily basis. People will come in from 10, 20, maybe even 30 years ago and say, what you did was the single greatest thing I could have done for myself. And so it's just changing things. And I'm one of those people that I had laser vision correction almost 29 years ago in April. I, for the most part, hated glasses, became contact lens intolerant. I'm very active, and I just wanted to be free of those. And I've been free of glasses or contacts for literally almost 30 years. I do have some readers when I'm reading small print, but that's based upon age and would be expected. I did both eyes for distance, and it's really held. At some point I'll need cataract surgery, and that will change things, but the freedom of glasses has been wonderful. And I think the reason I like doing what I'm doing is we get to do high technology, and that things are always changing. Things are always getting better. So what I was doing 30 years ago, I still do some of that, but the technologies have evolved that we can help more people with different scenarios and get them to where they want to be for the rest of their remaining years.
Excellent. What I wanted to do now, ladies and gentlemen, is I kind of want to just, I'm going to show you on the screen just sort of all the different questions that we're going to go through. And then what I'm going to do as part of our time together is I'm just going to take the slides off, and just Dr. Doane and I will have that conversation. We're going to talk through LASIK, SMILE, ICL, and refractive lens exchange. I know that's a lot of acronyms, but just being able to kind of help you in a very easy way to understand what options are available. We're going to go through all the different procedures and who they're intended for. We're going to talk about refractive lens exchange. We're going to talk about can you have refractive lens exchange if you've had LASIK? I'm not going to you can kind of see the question on the side there. I don't want to go through them all, but is there pain? Does it treat astigmatism? And so those are a lot of the kind of the questions, potential side effects, pricing and all that stuff. So, Dr. Doane, I just also want to let you know we've got a couple slides here that if you wanted to detail out to talk about the eye, I can pull it up, as well as for LASIK, SMILE, and then refractive lens exchange. So I'm going to kind of just pull down the slides, Dr. Doane, and I wanted just to start out with that journey that the human eye is on. And so what is actually happening to people throughout their life, and how LASIK and SMILE and ICL might be good for them in their younger years, and what happens to their eye as the age, and maybe how refractive lens exchange is the right choice. So anything about that journey that the eye's on, and how the procedures kind of fit into that bucket, if you will, please.
Sure. So virtually everybody that lives at some point will need glasses or contacts to help them with something. And that something is distance, intermediate, which we'll say is computer screen or dashboard, or near. So virtually everybody at some point is going to need help. So for example, when got to high school, I did not need glasses for anything. I thought I had absolutely great distance vision. But so many people start out life, they need glasses to see the chalkboard. So they're nearsighted. So those people really fall into a great category for laser vision correction, that being LASIK, SMILE, or PRK. And those surgeries are done on the front surface of the eye, the cornea. And that is a really good procedure. Again, if you're nearsighted, with or without astigmatism, and really works well till about age 50. At age 50, things kind of change because now we're dealing with not just the power of the eye, but also the lens inside the eye that's quit working. And that's where we sometimes migrate to something called refractive lens exchange. And those people, we're trying not only to give them distance vision, but also give them intermediate and near vision. So essentially making them functional with no glasses at all. The one thing I failed to mention was something called the ICL. It's
Mm.
also called the implantable contact lens, implantable columnar lens. It is a procedure inside the eye, really for people under age 40 with higher prescriptions, or people that are not a candidate for LASIK, SMILE, or PRK. And then lastly, when we eventually, as we age and our lens inside of our eye becomes cloudy and starts affecting our vision, then we do something called cataract surgery. Now, that if you live long enough, everybody's going to have cataract surgery. The one thing we will talk about, Michael will bring up, is something called refractive lens exchange.
Yeah.
Refractive lens exchange is the exact same procedure as cataract surgery, but for people that don't have cataract, but are not great candidates for what we do for under age 40, or even for ICL.
Yeah, and actually, I was going to pull up just while we're going through that. We've got a slide here, so we've got if you wanted to maybe talk about the difference between the procedures on, and we've got the eye here, and then I also can kind of flip down right here and talk about the refractive lens exchange. Any comments on this?
Yeah, sure. If you want to come back to that prior slide, and I'll just let you
Yeah.
use the pointer. If you want to run the pointer, the cursor on top of the cornea. So the cornea is the front part of the eye, and that's where LASIK, PRK, and SMILE are done. And then go
Yep.
back to where the lens is, little cursor back there. Or
Oh, right here. Yeah,
yeah,
yeah, yeah,
yeah,
right here.
right there. That's fine. So that's where the lens is, and that's where cataract surgery is done. And we will also replace the lens you're born with refractive lens. With a refractive lens, we can treat nearsightedness, farsightedness, astigmatism, and then also help with focusing up close so you can avoid reading glasses. And then with an ICL, I don't know if you have an imagery of the ICL, Michael. That'd be great if you do.
Yeah, I've got the for LASIK, and then I've also got it for Smile, but
SMILE. It's all right.
yeah.
We can come back to that. Maybe go to that first image if you would, the
Yep, there
first
we
one we
go.
had. One more, I'm sorry.
No, that's fine. There
There
you
you
go.
go. Yeah. So now if you could go,
Oh, I think your internet froze there.
can you hear
Oh,
me,
there you go.
Michael?
Your internet froze there. Sorry. Go ahead.
Yeah. So if you can put the cursor on the iris, that would be great. So what we do with the ICL is the cornea we don't touch the
Yep.
lens, but we insert a lens right behind the pupil, that open space, and in front of the lens. And this is to resolve astigmatism and nearsightedness, usually larger amounts of nearsightedness for people that are not candidates for laser vision correction.
Got it. Yeah, one thing, ladies and gentlemen, what I want to do is I'm actually going to launch a quick little poll here. And I'm going to launch it. It's going to ask you a couple of questions, which is, the first of which is just so we get a bit of a feel for who's here on the webinar. How old are you, right? So if you wouldn't mind putting that in. And then I also wanted to ask the question of if you've had LASIK before. So sometimes people have had LASIK and they're now in that age where they're seeing what's going on with their vision. And so actually, Dr. Doane, this is quite interesting, is that we've got over 67% of the people that are just responded or have actually had LASIK. Almost everybody is in that, we'll call it the RLE age, the 45 to 65 range. So this is quite fascinating, is that we've got a good amount of people that we've already done or have had surgery done potentially at our practice. And now we're in that sort of phase where they're experiencing the aging process of the eye. So ladies and gentlemen, thank you. I'll stop right there. And just to kind of show you the results, it's quite interesting. So with that in mind, I think that Dr. Doane, I think that one of the things is many people have probably never. Let's actually go back to the question about refractive lens exchange, because I think that this is something that many people have probably never even heard of that procedure before. And so let's spend a little bit of time of like a person comes in, they have their initial examination at our practice. What's that process going to be like about how we're able to help identify what the best choices are for them with their vision, specifically with refractive lens exchange, please?
Sure. I think this would be great. Can you go back to the slide of the image that we were just using, and then we can kind of describe
Absolutely. Yeah.
what's
I've got
transpired.
one here for RLE if you want it, but I can also just go to this
That
one.
one, that one there,
You got
perfect.
it.
So if you put the cursor on the cornea, everybody will know that they had surgery on the cornea.
Yep.
You can put the cursor on the lens, the crystalline lens now.
Yep.
So your cornea, after you've had LASIK, the cornea for all practical purposes is not going to change. Roughly by about 3 months, it is completely stable. The thing that has changed over years after somebody's had laser vision correction is where the cursors, and that's the lens on the eye. The lens is very active metabolically and is always growing. And when you get cataract, it clouds, but before it clouds, the power can change, and then you also lose the flexibility for focusing. So people that have had LASIK, they do great, then it quits working, so now they're in reading glasses. So
Yeah.
did the LASIK wear off? No, it didn't wear off, but your eye has continued to change, and you get this big word called presbyopia. And where we can help those people, if they say, hey, I'm not where I want with distance vision and I want to see up close, then we typically will go with a procedure called refractive lens extraction or replacement to put a lens in that will allow the person to maintain their distance vision but regain their intermediate and near vision. So it's really powerful from that standpoint. And you would do that one time in your life. You would not have to do cataract surgery down the road. So if you said, gee whiz, I'm 50, 55, I had great vision with LASIK or SMILE for 20 years, but now I'm not where I want to be. Refractive lens can give you that function back. And if you've lost near, we can give that back. If you've lost some of your distance and you want to sharpen that up, we can also sharpen that up with lens replacement.
Yeah, and that kind of begs the question right here, which is, can I have refractive lens exchange if I've had LASIK in the past? And the answer is yes, but any other color you'd like to add to that?
Yeah, so the one thing that we do have to make some adjustments, but that's all on our end. For people that have had laser vision correction, there's really two major measurements. The length of the eyeball, we know that that's going to be accurate, and the curvature of the cornea. The curvature of the cornea for a person that hasn't had LASIK is one thing. When they've had LASIK, it's slightly different as far as what we put in our computer programs. But the bottom line is the patients get a great result either way.
So let's talk about these procedures, and if you want, you can answer everything from LASIK and ICL through RLE. It'll be easier that way if we kind of just bundle them all together. But person comes in, they're identified that they're a good candidate. That's the next step, is like having that actual evaluation. So if you wanted to talk about what happens at the evaluation, you please do. But then also, okay, the day of the procedures here, what is that experience like as far as timing? Will they feel any pain? So I think that's sort of that journey once they come in the clinic. Anything you'd like to say on that, please?
Sure. So I think that if we kind of break it down age-wise, so let's say you're taken from age 18 to 45, and the person's nearsighted and they have astigmatism, those people are probably the best candidate for corneal refractive surgery. So LASIK, SMILE, PRK. And as long as they're within a suitable range, they would come in for an evaluation. We get several pieces of information. What's the health, the overall health of the patient? What's the health of their eye? And then the parameters of the cornea is what's their corneal curvature, what's the length of their eye, what's the power of their eye. And if they fit within the parameters of the procedure, then okay, corneal surgery would work great. If they're beyond that, that's where somebody might become an ICL. And again, we're talking about patients age 18 to 45 that are nearsighted and with astigmatism. We have found that people that are farsighted, laser vision correction does not work as well. So then we're kind of tend to migrate those people more toward refractive lens replacement because it's much more powerful, more enduring long term, and the quality of vision is so superior to what we can do with laser. But nearsighted, laser on the cornea works fantastic. As far as people that come in for laser vision correction, we do multiple. We have people come in locally or people come in from multiple hours out. Some of those people come in, we may have done a virtual consult with
Yeah.
them just to get their parameters. They'll literally what happens, they might come on, they might show us their contact lens case. Hey, I'm a -3. We know at that point that they're a good candidate in all likelihood. There's still some things we have to do in office. That person can come in with what we call a C-do. They come in, we see them that day. If everything looks good, then they can have surgery and then they'll do their post-ops, then head back home. We'll do a virtual 24-hour post-op and then they will have a post-op either locally or with us, locally back home or with us here in Kansas City. So
Yeah.
that would be laser vision correction. If somebody does ICL, it's a little bit more involved. There's surgery. We do go to an operating room for that. We see those patients, I should say the laser vision correction patients, when they're here, day of surgery, they're here about 90 minutes. If they're doing a full eval, maybe 2.5 hours, the hour for the eval and then an hour and a half for the entire process for laser vision correction. ICL patients will spend about 90 minutes with us. Typically, we'll do both eyes same day for laser vision correction or ICL. Post-op day one for ICL, we see them in a week. The ICL patients almost universally are fully functional the next day, just like laser vision correction patients. Fully functional, be able to get back in all activities, physical activities, workout, golf, swimming, and so forth. Refractive lens, a little bit more involved in the sense that a little bit more on the pre-op part. There's a full pre-op. You are going to the operating rooms. We then would do surgery, again, spending 90 minutes to maybe an hour or 2 hours with us. Most of
Mhm.
that is on the front end to dilate the patient. The surgery itself is short. For all of these patients, as far as pain intraoperatively during the surgery, usually near zero. After surgery, once the numbing drops wear off, there's usually about 30 minutes to maybe 4 hours where you can have foreign body sensation, tearing, light sensitivity, but almost like snapping your fingers about 3.5 to 4 hours out, that goes away. Almost everybody we do surgery on should be fully functional the next day as far as activities and comfort, being able to drive themselves and so forth.
Amazing. I've got a big question which we haven't asked yet, which is if somebody has refractive lens exchange today, will they need to have cataract surgery in the future? So I think that's a huge point that I think people will want to know of like, okay, like I like the idea of getting the having my vision taken care of now to enjoy the best years of my life without having to, have this degrading lens in my eye. But am I going to need to have cataract surgery down the road if I have RLE today? What are your thoughts?
You will not. So the same organ that creates cataract, we're removing that before the cataract evolves. So we're essentially giving people function back so they can live, let's say, from, I'm just going to throw out number 50 to 80. And I would typically think they would need nothing else done because there's essentially three parameters that will determine the power of your eye the rest of your life. And some people will come in and say, well, gee, I go to the eye doctor and every year my prescription's different, or every couple years my prescription's different. And the reason it's different is the lens inside your eye. And that lens inside your eye we're getting rid of. So that variable is gone. So there's really three variables for the power of your eye. Length of eyeball. By and large, once you get to about age 20, the length of your eyeball is not going to change. The curvature of your cornea, it's pretty much stable for most people. I'll come back to that in a second. And then the lens inside your eye. Once we replace the lens inside your eye with effectively a piece of plastic or an inanimate object, if it stays in that same position, which it should, it's not going to change. In fact, that lens would be good for many lifetimes. So the three variables, eyeball length is not going to change. The lens is not going to change. The only thing you're left with is the cornea. There are some people, another billion blinks, and they can get some astigmatism that can always be
Mm.
treated with whatever. contacts, glasses, laser vision correction. Myself, included 29 years ago, I had LASIK. My corneas have not changed. That would be a typical that they would not change. So once you do refractive lens extraction, there's really nothing else that's going to occur as long as your eyes stay healthy, no retinal disease, no glaucoma. Your vision should stay the same. That vision should stay the same for distance, intermediate, near. So you're not on that. Once we take care of the lens, you're not on that track where most people, their vision continues to get worse from age 40 to age 65 for reading. Once we get you set, then your reading vision should be good the rest of your life.
We'll jump into back to astigmatism, but you did talk about lenses, and I think this is a good opportunity for us to maybe talk about that, specifically for the refractive lens exchange crowd. So, and that's one of the beauties right now is that there are so many amazing lens options that are available to people, the light adjustable lens and other ones, which I'm sure you can talk about. Anything you'd like to mention about how we can customize the approach for somebody at that initial evaluation and recommendations based upon how their vision is, how they want to be using their vision in their life, and how we select the right lens choice for them. What are your thoughts?
Yeah, so the full spectrum of lenses are really the following: a spherical lens, a toric lens, a multifocal lens, or something we call a term light adjustable lens. We effectively have eliminated the toric lens for most people because the light adjustable lens treats astigmatism and it's much more precise in treating astigmatism. So now you're down to three choices: a single focus lens, a multifocal lens, or the light adjustable lens. Multifocal lenses we've used for, gosh, almost 30 years. There are some limitations with night vision, halos, and quality of vision. So we've effectively kind of migrated. The vast majority of our patients are either going to get a single focus lens or the light adjustable lens. We love the light adjustable lens for refractive lens replacements because those patients typically want to be rid of glasses for everything, distance, intermediate, near. So we're treating astigmatism, and then we're going to alter the power of the eyes based upon what the patient wants. And if the patient says, I really want to be free of glasses for everything, their dominant eye, we're going to set for perfect distance. For their non-dominant eye, we're not doing monovision. Monovision is a huge separation between the two eyes. We're doing a very small separation between the two eyes to where the, if you want to call it the blended eye or the near eye, is still legal driving vision, but it also allows you to see reading and computer. When we do monovision, we lose certain brains, and that's when with contact lenses or LASIK, the separation is so big that about 30% of brains can't tolerate it. But with blended vision with the light adjustable lens, probably 98, 99% of people do really well with it, and it affords them the possibility of no glasses for distance, no glasses for intermediate, no glasses for near in 90 to 95% of patients.
Yeah, and I think that for those of you that are on watching our time together, you don't need to make that decision which one makes the most sense for you. We do that at the initial examination where we kind of have that consultation and you'll chat with our doctors and whatnot. Dr. Doane, you mentioned astigmatism in a previous question, and I think that that's something that maybe is one of those things that in ophthalmology people don't even know what it is. And so, what
Mhm.
exactly is astigmatism, and is it treatable with all the various modern vision correction procedures we have?
Yeah, good news. We can treat it with all modalities: glasses, contact lenses, or any form of surgery that we do. Effectively, it's the following: your eye can be the shape of a tennis ball, that's spherical, no astigmatism. If your eye is shaped more like a football, long curve, long gradual curve, and short steep curve where you put your hand around, that is astigmatism. So what that does for somebody's vision, if it's not corrected, if you were to be looking at a box, 1 foot vertical, 1 foot horizontal, that's a square. But if you have astigmatism, that image actually looks to that person like a rectangle, tall and skinny or very short and fat. So by treating the astigmatism, we're going to get that proportion accurate. The square should look like a square, a circle looks like a circle doesn't look like an oval or an egg shape. So treating that astigmatism is very important because if somebody has a lot of astigmatism, and let's say they do lens surgery or you would do laser vision correction, and you don't treat that and don't correct it, they will not get to 20/20. So it's very important to treat it. Then you got to say, well, what percent of people have astigmatism you have to treat? Probably every bit of 70 to maybe even 85% of patients have enough stigmatism you have to treat it. And we can treat either really low amounts or gargantuan amounts. the interesting thing, Michael, is that I would say over the last 30 years, I can't tell you that virtually probably every week there's somebody that comes in and says, my eye doctor said that laser vision correction
Yeah.
cannot solve astigmatism, where we know it can and it has for the last 30 years. So it's either misinformation or miscommunication, but astigmatism sometimes is very hard to treat with soft contact lenses because
Yeah.
they're ballast weighted. Every time you blink, you get this weird vision. And glasses are not ideal for astigmatism, but laser vision correction and implants are really an ideal way to correct astigmatism.
Here's a very common question, which relates to whether it's LASIK, ICL, SMILE, RLE, all these different procedures. Does somebody have it done once, or do they need to have it done multiple times? So that's a very common question people would have. What are your thoughts on that?
Yeah, so for laser vision correction, this is like doing archery. We'd love to hit the bullseye 100% of the time. It depends upon the amount of correction, but the likelihood of somebody needing a second surgery or an enhancement surgery is very low, less than 5%. The lower you start out, the less the chances are. So probably the worst case scenario might be 3% of eyes that are really high corrections or high astigmatism may need a second surgery. That first surgery usually gets them to legal driving, but we know most people want to be 20/20. So we take them from not seeing the barn to seeing the barn, seeing the barn door, seeing the sign on the barn door, but not seeing the smallest print on the barn door. And that enhancement will help with that last part. As far as lens implants, typically with lens implants, it's one surgery and done. And with the light adjustable lens, since we put the lens in the eye and then we adjust it, effectively everybody gets everything they want. I mean, 99.9% of the time, you're spot on target with the light adjustable lens.
I know that's such an amazing lens, isn't it? That's something that's made a huge difference, I think, in the last 3 to 5 years, is that lens
Mm-hmm.
coming into the market. On just another common question, and we're kind of nearing the end of our questions, ladies and gentlemen. So if you do have a question that you would like to ask Dr. Doane, please do so. I'll continue on with this question. My question is side effects, right? So that's a natural question and concern that people have. What do people need to be cognizant of, as with any operation? There are things to consider, or any procedure, there's things to consider. But anything on side effects you'd like to mention that people should be cognizant about, please?
Yeah, I think, if you look at numbers, the side effects and complications are incredibly remote. The number one thing I'm really looking for, are we on target? And what that means for the patient, can the patient see the way they want to? If they are seeing the way they want to, then I'm usually, hey, hooray, we're done. As far as side effects, complications, when you see a consent for any type of surgery in the United States, there's going to be a long laundry list of things that happen. They are incredibly uncommon. The things that are probably most concerning for any doctor are infection, but we treat people with prophylactic antibiotics before surgery and during surgery to minimize that. That is very uncommon. With corneal laser vision correction, it would be one in many, many thousands. With intraocular lens placement, it's one in several thousand. And the infection is possible, incredibly unlikely. But again, we use prophylactic antibiotics, if you didn't hear that part, during surgery and after surgery to make sure we're in good shape.
Excellent. A couple or just one other remaining question, and I'm going to go through pricing and whatnot because I know that people have those questions. We did talk about the different lenses, and as far as, and I'm talking about refractive lens exchange, about what they should expect as far as their vision. But maybe just one more time, what can somebody expect as far as what to see at a distance and up close? Anything you'd like to say is like expectations on outcome from refractive lens exchange, please.
Yeah, with refractive lens exchange, I mean, we are swinging for the fences. So with the refractive lens, if a person says, hey, I want absolutely perfect distance vision, I'm swinging for the fences. So whatever the retina will let them see. So I'm targeting, let's say 20/20 for distance. But I'm also, for the vast majority of patients that do refractive lenses, I want them to be free of glasses for computer screen, and I want them to be free of glasses for phone, tablet, um, a laptop computer. So the overwhelming majority, well over 90, 95%, that is the case. Would they ever need glasses for anything? Well, sometimes people want perfect distance vision, both eyes, while they're driving on the highway at night at 80 miles an hour. So that may be a thin pair of glasses, no power in one eye, just a small power in the alternate eye. Or if somebody's doing minute, you know, activities, some type of hobby where they need just precise vision. That may be a thin pair of readers for that. But 90 to 95% of patients 24 hours a day should not need glasses after refractive lens replacement.
I'm going to jump in. We're going to talk about pricing and then insurance and financing, whatnot. And please feel free to kind of add anything to what I mentioned. So one of the questions that people have is this typically, or any of these procedures covered by insurance? Refractive lens exchange is not, in the sense that it's not covered by like Medicare, Medicaid, whatnot. But you will find sometimes an employer where you can use a specific, your HSA or FSA plans to be able to pay for the procedure. On the laser, the corneal-based surgery side, sometimes that is covered by vision plans. The best advice that I would give to somebody is to actually go and talk to the benefits manager or HR manager for that. Specific things on pricing. So for LASIK, on average, I would say it's going to be between $2,000 to $2,500 per eye on average at our practice. For ICL, that's at $4,650 per eye. And then for refractive lens exchange, it's at roughly $6,000 per eye for that procedure. The variance in pricing, the lenses obviously are the most significant cost, as well as just the actual effort it takes for that procedure. But the biggest thing I would mention for everybody is that financing options are amazing. So we've got great financing packages to be able to make it palatable with your monthly budget. And we kind of go through all that at your initial examination. Anything I've missed there, Dr. Doane, that you'd like to add, please?
No, I think you're exactly right. And again, we have a lot of patients that have accrued HSA savings. So either HSA or FSA, very common for people to use.
One thing as we're kind of rounding out our time, and again, we want to be respectful of your lunch. So I'm going to just put up on the screen here, just sort of like what the next steps are. The next steps is to have that conversation, and that is we'd like to invite you to come into our practice. You can be able to give us a call and have that initial examination. Could we just provide a little bit more color onto what actually happens at that consult? We take a very organic, patient centric approach, but what's that experience can be like, and what can they expect from that exam, please?
Yeah, I think it really boils down to, we want to hear what the patient wants. What do they not like with their current situation? And then we know what we can provide, and we're trying to see if we can get those two things together. We will get some metrics, length of some anatomical considerations, and is the patient a good candidate? But ultimately is, what does the patient want? And what we deliver, is it likely to meet those expectations? If it is, maybe that's a good marriage. If the expectations are beyond what we can provide, then we're going to have to say, hey, we're going to have to wait for different technology for that individual. So that's essentially the basics: is education, find out what's available. And if what we do works with what the patient is desiring, then that may be a place to go forward.
Excellent. Well, ladies and gentlemen, I want to thank you so much for your time, for your attention. Dr. Doane, thank you for the amazing answers. And we'll be able to send this recording to you so you can share it with a loved one. I'm sure if you've got questions as well. But I just wanted to take a moment and thank everybody for your time. Dr. Doane, I'll give you the last word. Any final thoughts, please?
No, all good. We're more than happy to help anybody that needs some assistance in decision making. The biggest part of what we do on a day in, day out basis is purely education. I'd much rather have the person asking tons of questions to find out if what we can provide kind of fits with where they want to go.
Excellent. Thank you so much, everybody. We'll be doing more webinars in the future. Have a glorious rest of your day, and thanks again for your attention. Thank you.